Okay, for this lecture, we're going to be covering professional attitudes and communication. It's chapter 6 in your patient care book. And there's a lot of lists: need, communicate, establish, compare. Make sure that you're able to define these so that you can do well on your exams. So there's some key terms. Make sure you know what the key terms are. And when we're looking at issues of cultural diversity, there's a whole scope of diversity. And each one of us is biased based on our upbringing and our backgrounds. So you have to be very, very careful to not discriminate against anyone at any time, even when you don't think you are. Sometimes you have natural biases based on your religion, whatever. So you need to be very careful when you're talking to patients and working with people that you're respectful. So, culturally significant attitudes that may impact communication and how cultural issues may affect care and professional responsibility and ethics in relation to diversity. So we're going to cover each of these. So the scope of diversity. So the racial and ethnic national characteristics of individuals were originally identified by specific areas of the globe. So skin color, hair texture, the shape of facial structures or features describe cultural and ethnic origins. So culture is determined by language and customs commonly observed, and cultural diversity emerged throughout different cultural groups. So looking at the scope of diversity, some examples are gender groups, male versus female, racial groups, generational groups such as baby boomers. There's the West Coast people. You always hear about California girls. It makes me laugh. Sexual preference, religious groups, groups based on non-racial physical characteristics such as blind people, deaf, disabled, obese. Social economics, so low income or very well off. Groups of various types of family structures, so they're single and married. All of us fall into these different groups of diversity. So attitudes. Now, when you're talking to patients, there's usually eye contact. You can touch the patient. There's gestures, and they all can mean different things. So it's like a soft touch on the shoulder is something endearing, where other people, might find that completely offensive. So it's important to know the meaning of the culture in the area in which you live. So with today's world, everyone is traveling a ton and everyone's moving to different countries. And it's very, very important that you understand that you don't shake with your left hand. You don't wave with your left hand for some people. I was in Indonesia for the tsunami aid and I had my arms full, so I waved with my left hand. I had about 6 machine guns turned on me, screaming and yelling. I didn't know what was happening. So that's an extreme case, and I never waved my left hand again because I guess the left hand is the hand that they wipe with, and they find that completely offensive. So I had no idea. So just be careful in what you do and what you say. So how cultural issues may affect care. So men versus women perceive healthcare completely different. Women are more proactive, more educated typically than men in healthcare, and women will go seek treatment where men don't like to go to the doctor, so they just don't go. The elderly population, they think doctors are amazing. Whatever the doctor says is what's going on, and they never question the doctor. They are powerful. There's geographic, so urban versus rural, and religion, so Islamic versus Catholicism. So in 6.1 of your book, it actually has a whole big green area for you to look at, Anglo-American, African-American, East Indian, Asian, Middle Eastern, Native American, and it talks about what the norms are for that particular group. So very interesting. If you find there's a hospital I worked at and it was mainly Persian. Great. Okay. I didn't speak Farsi. It was kind of a problem, but you know what? I learned their culture and I learned how they like to communicate and I learned how they like their care, and it was awesome. It was a lot of fun. I like having a mixed, I call it a mixed bag, a mixed bag of people because it teaches me so much about human nature. I love it. So this is the 6.1 in your book is all the different areas. So even Russian, they talk about Middle Eastern. Very interesting, very interesting. Who likes eye contact? Who likes to be touched? Who's allowed to be treated by women? Women may only want women, treating them. So very interesting. You should read it so you have a better understanding and you can better care for your patients. Okay, your professional responsibility and ethics in relation to diversity. You actually have a professional responsibility. The ASRT has a code of ethics and it requires radiographers. And if you're an MRI, this does fall under radiographers. So you will be upheld to these ASRT standards. So make sure that you put aside all your personal prejudices and emotional biases and you render service to humanity with full respect for dignity and mankind. The one thing that I completely don't understand is those of us in healthcare and the people that are discriminatory. It drives me crazy. Even out on the street, I'll be, someone will yell out some kind of racial slur. The thing I don't understand is it's just the color of our skin and the shape of our eyes. Inside our bodies, every one of us is exactly the same. Well, we're supposed to be exactly the same. Sometimes people have extra parts or missing parts, but our muscle structure, our bone structure, everything is the same. So how we function, our digestive system, our metabolism, it's the same. So it's so odd to me to hear that people aren't respectful just based on the way that we look. Very sad. Okay, so when we go into communication skills, there's nonverbal communication, listening skills, verbal skills, attitude, and validation of communication, and communication under stress. Now, communication under stress, that's a big one for us. So if we go to nonverbal, examples are eye contact, touch in a positive or more of a violent, firm way, and appearance. So does it look like you picked up your scrubs off the floor and came into work and didn't brush your hair? So be neat and clean. Make sure your scrubs are not wrinkled and not stained or dirty or have, gadolinium or barium all over them. And make sure you present yourself in a way and you have a softer look to your face, not a stern, mean, look. So all of that is examples of nonverbal communication. Listening skills. Okay, so this is hard, especially when you're busy. It requires more than waiting your turn to speak. It's a two-way street. So the ability to give the speaker full attention and focus. Really, really hard when they're going on and on and on. So you got to redirect the conversation, validate what they're saying, and get to the key points so that you can get the information down for the doctor. Verbal skills, ability to use language and content that is appropriate for your patient. Speak face to face. Don't turn your back and write down stuff while they're speaking to your back. Make sure you turn and face the patient and talk to them. Be alert and modify verbal skills if approach isn't working. So if the patient isn't responding to you, find a way to get them to respond to you. Attitude. So nonverbal cues communicate attitude. So your tone of your voice and the choice of your words. So if you're like, hi, Miss Smith, or, oh, hi, Miss Smith, how are you today? So there's a big difference in your tone. So be careful of your tone because some of us portray, and I was guilty of this, when I'm stressed or I'm upset or I'm behind, my tone definitely showed that I was in a hurry. So your next scan is going to run you about 30 seconds. And it's like, really? I couldn't take an extra 2 seconds to say, your next scan is going to run you about 30 seconds. Make sure you hold very still and then run my scan. Or, Miss Smith, go ahead and take in a deep breath for me and hold it. Instead of saying, that's better than saying, taking a breath and hold it. So you got to be real careful. Assertive. So You need to be calm and firm expressions. You need to say, I really need you to hold still. It's very important to get a good, exam. You don't want to be like, hold still. So very important that you express yourself. Okay. Being firm is not the same as aggression. So make sure that you're not being aggressive with the patient, that you're just being assertive. Assertive and firm. It's really, really important that you take those yoga pants off. There's metal in there. We need to see to get a good diagnosis, whatever. Okay. So validation and communication. This is important. So an indication of clear understanding of the message. So reflects the elements of the speaker's statements when you respond. So repeat back. Oh, I understand that you said. So make sure that you validate what they're saying and you're able to do it in a way that they understand you understand. So without validation, neither party can be certain that all elements of the message have been understood. Ms. Smith, you're telling me that you've had pain for 6 weeks and the pain is in your right lower quadrant or, is your, lower abdomen, whatever. So they may not know quadrant, but we do. All right. So communication under stress. Stress interferes with our ability to process information accurately and appropriately. So suggest to improve communication in a crisis situation, lower your voice, speak slow and clear, be non-judgmental in both verbal and nonverbal cues. Do not allow another's inappropriate actions or speech to goad you in your similar response. Request confirmation when you are uncertain of the listener's understanding. So a lot of the times we are stressed, especially in a trauma facility. It brings a higher level, especially in a 3T magnet. It is really, really hard not to hurry some along, not to be on schedule. So don't let the patients ever see that you are stressed because that's just going to amplify their stress also. All right, so therapeutic communication. And what this is you address the patient, you validate choices, you avoid assumptions, and you have assessment through communication. So therapeutic communication is a process in which the healthcare professional consciously influences a client or helps the client to be a better understanding through verbal and nonverbal. Communication involves the use of specific strategies that convey acceptance and respect and encourages the patient to express feelings and ideas. So really, really important. So deterrence to therapeutic communication. So there's some techniques and examples for you to see. So rejecting, I don't want to hear about, or disapproving, that's not a good thing to do. I wish you'd stop that. Disagreeing, I don't agree with that. That can't be right. So you need to be careful. You need to make sure that you are always on a positive, never belittle the feelings. Make sure that you're empathetic and that you are able to keep the patient going in a positive experience within our department. They're only with us for a short period of time. Just remember that. All right, so addressing the patient. Normally you should call the patient by their name, and I prefer Ms. or Mr. Ms. Smith, Mr. Smith. So avoid calling the patient by the exam. This actually happened to me. I was getting a Holter monitor for my heart to monitor my heart. And I was sitting in the waiting room. There's about 50 people in the waiting room. And they came out and they said, Holter monitor, Holter monitor, Holter monitor. And I just sat there. I could not believe what was happening. I'm looking around and they go, Foster. I was like, what just happened? So it does happen. Do not call a patient and say, I have an MRI of the knee for Mrs. Smith. No, you are not allowed to share what the patient is having done. I spoke to the facility and I went back again to return my Holter monitor and they did it again. I could not believe what I heard. I was like, okay, that's just not okay. one of the sites I worked at, we had an intercom system that went throughout the whole place, and the the patient had registered for a mammogram, and they finished processing the paperwork, and they called overhead, mammo ready. And so the patient came unglued because there was only two of them in the waiting room. It was a gentleman and the female. So the gentleman knew what exam she was having done, and she came unglued, and righteously so. So we changed our system after that. So no one needs to know what kind of exam a patient is getting. So this is very real, and it does happen. This was just a few years ago. So make sure that you maintain that person's dignity. Don't share the exam that they're doing. No honey, sweetie, nothing like that. People find that offensive. So, stick to names, please. Some facilities will only let you call first names. That's fine as long as you identify the patient once they're away from everyone else. All right, so valid choices defined as alternatives that are acceptable to you. Provide the patient with a sense of participation in his or her care. So, Ms. Smith, we're going to be doing a knee x-ray today. I need you to get changed. Would you like the gown, two gowns to make sure you're covered front and back? So get them involved in their care. They're more likely to participate if you're involving them. So it's really nice to do that. It gives them a sense of ownership. So important. Avoiding assumptions. So help in preventing errors during the procedure. Examples of common assumptions: use a routine positioning for all patients. Now you can't do that. You have to make modifications, use sponges, whatever you need to do to get the best views that you can for that patient and make them comfortable. So patient understood and followed preparation for the procedure. So for contrast, so a lot of patients say that they did the prep, then they didn't do the prep. So make sure that they did do what they said, what we actually asked them to do. Assessment through communication. So combining observing with therapeutic communication determines patient ability to cooperate with exam. Really, really important. So if you said, okay, I want you to change into this gown, and you come back and they're still sitting there and haven't changed, you know that you're going to have some difficulty with this exam. So converse with the patient to ensure they understand what you're going to be doing. So really important. We're going to be doing a knee x-ray or a knee MRI. I'm going to have you lay down on this table. You're going to put your knee right here and then just look at you. So you may have to show them what you're going to be doing. So really important that you are able to adapt to your patient based on their level of cognitism. All right, so special circumstances that affect your communication. So patients who do not speak English, the hearing impaired, deafness, impaired vision, inability to speak, we call that aphasia, impaired mental function, and altered states of consciousness. So that definitely will. So important to recognize sensory deprivation or loss, but loss does not affect mental capacity. So treat patients who are deaf, blind, or speech impaired with respect. So it's not okay for you to be upset or put off by this. It's important that you take the time to work with them. And I can tell you it's really hard when you are behind. Patients who do not speak English. So federal law guarantees patients' right to effective communication. So a lot of the large hospitals employ interpreters and provide signs in multiple languages, so that helps. Other facilities have on-call interpreters. That is very common. You'll see a special colored phone, and that's for interpreters. So there's family members that say that they'll interpret. Really important that you're careful with this. The hospitals don't want you to use family members only because they will filter. They don't want the person to know all the information, so they pick and choose what they're going to share, and that's just not okay. All right. People who don't speak English. So when you use an interpreter, make sure you look at the patient, not the interpreter. So it makes the person who's having the exam feel excluded, and that is just not okay. So I'm guilty of this. It's hard for me to give all the information and watch them give it to the patient. So when you're giving the information to the patient, and you're going through the interpreter, face the patient, speak to the patient, not the interpreter. Hearing impaired. Okay, so these are patients that are hard of hearing. They're not deaf, but they're hard of hearing. So talk to these people. Square off. A lot of them will read lips to assist them. So get the patient's attention before beginning to speak. Face the person and make sure that there's light on you so that they can see you. Hearing loss is frequently in the upper register, so speak in a lower tone. So speak clearly at a moderate pace and do not shout. So no yelling at the patient. A lot of times they'll say, speak in my right ear, please. So I'll lean over to the right ear and I'll speak more on that side. Okay, avoid noisy backgrounds. If they have hearing aids, the hearing aids pick up all the background noise, so be careful that it's quiet. If they don't understand what you're saying, rephrase it so it's in something maybe easier for them to hear. And be patient. They are upset typically that they can't hear you and they want to hear you. So take the time and really make sure that they understand. And that's where that effective communication comes in, and you get feedback from the patient to ensure that they understand. Okay, so patients that are completely deaf. So it's like a whole nother world. The chart should be flagged, so when you call the patient, they're not going to hear you. They'll be in the waiting room and they're not going to hear you. You're like, why? Where's Mrs. Smith? And you can't find Mrs. Smith. So make sure that you know that they're deaf. So there's certified interpreters usually necessary for communication. So you'll have sign language. One way we get around that is we write notes for them and write down exactly what they need to know and what we need them to do. Vision impaired. So the ability to function depends on the degree of vision loss and length of time since they lost their sight. So it's useful to ask what assistance they need. So some prefer touch on the elbow for a guide. Others prefer a description of the surroundings. Okay, in 3 feet you have a step. So very, very important that you ask them, how can I help you? So knowing what they want. So a lot of times they're like, grab my arm, use my lower back. I want you to guide me where we're going and explain what you're going to be putting me into. You know, I'm going to be walking you back. It's just around the corner. I'm going to give you a gown I want you to change into. You'll be in a small dressing room. There's a bench right behind you. I want you to sit on that bench, and I'm going to come get you in about 3-4 minutes. So be very, very clear on your directions on what you want them to do. So inability to speak, so aphasia. So it's a loss of the language function. Some patients who had a stroke, they completely understand you, but they can't speak. So helpful to ask the nursing staff about useful methods of communication. A lot of these patients can write still and nod and be able to get hand gestures to get your attention. So really important that you pay attention to these patients and you find a way to communicate with them. Sometimes the family members will understand exactly what's going on because they're around the patient more. Okay, so impaired mental function. So abilities vary, so individual assessment is key. Inappropriate to treat adults with mental disabilities as if they were children. So repeating instructions a lot of times is useful. Altered state of consciousness. So important to communicate as if the patient can hear and respond. Constant observation is required to avoid any accidents, and don't rely on the patient to remember instructions. Patients are not responsible for their actions or answers. So they might be fine 1 minute, the next minute they're not. So be careful when they're on the table and make sure that you communicate with them so that they understand that you're there, you haven't left them, even though it's only been a minute. So very, very careful with them not falling off the table, getting scared. So age-specific care and communication. So we're going to go through all the different levels of age. So neonate and infant, so that's birth to 1 year. So behavior is reflective of influence in voice and touch. Usually babies like to be wrapped up real tight, so we'll burrito roll them they start crying, hold them tight. They like to feel secure. So rapid physical growth and development, keep infants and parents together as much as possible and provide a safe environment with familiar objects. So pacifier, blankets, smell, they recognize smell, so it's important to keep their blanket with them. Toddlers 1 to 2 years. Now, this is a tough age. In an MRI, we typically sedate these patients because they don't understand that they have to lay completely still for an hour. So that's just not going to work. For an X-ray, it's a challenge also. So they are little wiggle worms. They don't hold still for more than 2 seconds. So they have a fear and lack of comprehension. They communicate in 2 to 3 word statements, and they like to explore, so they're going to be all over the room looking at everything. They're attached to parents, but are starting to have some independence, so they'll let go of the leg and make a run for your tape or stickers or whatever. Use friendly but firm approach, set clear limits. Immobilization techniques need to be used, so explain to parents what you need them to do. A lot of times we'll get the parents involved, and you can get the exams done. Sometimes you're just going to have motion. That's just how it is. Distractions will help with the exam, and be careful, cheerful voice and short, simple instructions like, okay, stand right here, hey, look at this over here. So distract them and keep them engaged, and you're more likely to get your exam done. Now, an MRI, that's a whole nother ballgame. So preschoolers 3 to 5. So increasing independence and conversation. Encourage them to cooperate as much as possible. Don't use word hurt. Show them that it's just a picture. I usually say, do you want to see your picture when we're done? If you hold very still, I'll get to show it to you, okay? So I'll use little things, and I bribe them a little. I have stickers when we're done if you do a really good job. So set clear limits and reward for good behavior. So school age is 6 to 12. They can think logically, give concrete information, and be honest. Don't lie to them. So a lot of times around, younger they are, the more demonstration I'll use. 12-year-old, they can take verbal instructions pretty well. And it depends on the maturity level also. And if they've ever had this done before. So if they're 12 and they've had 5 chest x-rays, they know. If they've had, a brain scan every year, they know. So it's easy compared to a 6-year-old that's looking at the big, bore going, I'm not sure if I want to go in that. So you can, talk to them, show them that it's not going to hurt and it's going to be okay. So they're more logical. Adolescents, so that's your 13 to 18-year-olds. This is special sensitivity for emotional needs, so they may revert back to old behaviors. So show empathy, respect physical appearance and privacy. So they're starting to develop, and their hormones are kicking in. So they want to be with their parent, but yet they want their independence. So careful asking pregnancy in this age. You got to be able to get a straight answer, and they're going to lie if their parent's there. So usually as soon as mom or dad turns around, I ask it, I whisper it to them and to get an answer. So really, really be cognizant of their developing bodies and how they are embarrassed of it. So, and recognize their independence also. All right, so young adults 19 to 45. So involve patient and significant others in care and making decisions. So they're entering their adulthood, and they may have kids, they may be married, they may be single still. So very scary age when they're sick, because they're just starting off in their adult life and have responsibilities. They have mortgage, they have kids, they have, all of that. So it's a very scary time if they're diagnosed with anything. So middle-aged adults, so 46 to 64, may experience lifestyle changes such as chronic illnesses, so more long-term diseases. So this is me. I'm in this category, and yes, I get more chronic illnesses now. It's kind of a bummer. All right, so we're usually empty nesters, so it's a whole new phase of life. So late adults, so 65 to 79, it's usually our baby boomers in this area. So, and it's an extension of the lifespan. So back in the old days, people didn't live past, 60, 50. So now we're living longer. There's more chronic illnesses and there's cancer within that age group. So be sensitive. It's more of the end of life that they're looking at. They know that the majority of their life is over. So, it's especially if they're diagnosed with something, just be sensitive. And older adults, so 80 years and older. So that's a long life, long life. A lot of times they can't hear well, they can't see well, they have multiple different illnesses and ailments. So those are always my favorite to get into the scanner because they have to tell you about all their stuff. And they've lived such a rich life, they want to share everything. So they're a lot of fun if you have time. So age-specific care and communications, important to learn and practice age-specific communication. Avoid stereotypes like, oh, those damn teenagers. So avoid doing that because not all of them are the same. Some are very mature, some are very immature. And it's hard. I get it. I get it. I get it. So ageism is a discriminatory attitude toward the elderly that includes a belief that the elderly are ill, disabled, worthless, or unattractive. So be careful. Be careful. Oh, another 90-year-old. Gosh, they're horrible. They're so slow and they always are sick and smell. And no, none of that. None of that. So those are the people that you're caring for. And this is why we're in this business, is to help them. All right, so patient education. So there's patient teaching, communication with patients and families, dealing with death and loss, and communication with coworkers. So patient teaching. So opportunities during the examination or procedure while responding to patient concerns as a part of the instructions needed to prepare for the procedure and during the instructions for follow-up care. So it's really important that you provide written materials as often as possible, especially for complex preparation or follow-up. So if someone's on metformin, if you're going to give iodine, you need to make sure that you give them written instructions on not taking it. They are not going to remember all the details that you're telling them. So it's important to give them actually some kind of print instructions for pre-procedure or post-procedure because they're not going to remember. Communication with patients' families. So empathy and patience is required. It's important that you tell them where the restroom is, where the cafeteria is, where the waiting rooms are, how long you're going to have the person, any delays that you've encountered, and any follow-up care. So really, really important to say, I'm going to have Miss Smith for about 45 minutes. The waiting room is right here. This is where I'm going to come get you. The cafeteria is downstairs and the restrooms down the hall. I'm running about 10 minutes behind, so I'll get Miss Smith in the scanner just as soon as I can, and I'll come get you just as soon as we're done. So very, very important that you tell the family members all that information. Dealing with death and loss. So there's the Kubler-Ross stages of grief. So there's denial, so refusal to accept the truth, may refuse to discuss the possibility of loss or death. Then they go into anger, which is frustration, outrage, and may vent on healthcare workers. And yes, that's happened. Bargaining, attempt to earn forgiveness for the loss. Depression, often they get quiet and withdrawn and they just sit and cry. And then there's acceptance. So acceptance of the loss or impeding death that deals with life relationships on a more realistic day-to-day basis. So communication with coworkers. So cooperation with other healthcare providers makes it easier to accomplish the common goals for the patient. So good interpersonal communication skills are essential. So you need to have effective and efficient communication, and you need to be a good listener. Don't gossip. So that's the big thing. So if you are talking to your coworkers, it's important for you to understand the legal implications of communication about a patient. So If you are talking about how gross or nasty a oozy wound is, or if you're saying, oh my gosh, this patient has cancer everywhere, it's just so sad, and really, really important to know that you are breaking HIPAA and that you can be sued. So don't talk about patients. You can talk about your shift. You can talk about, anything to do with your job. If you do not have direct patient care with that patient, and you're just passing the information to the next person that's going to have direct patient care, you need to be concise in your language, and only if you're sharing that for patient care. You are not allowed to talk about a patient that you don't have care with. So if someone starts to tell you about something about a patient, oh my gosh, did you see that patient yesterday? No, that is a HIPAA violation. You are not allowed to do that. So you do not want to be sued. Okay, so that is your lecture on professional attitudes and communication.